This is Susan London reporting from the annual meeting of the American Psychiatric Association in San Francisco. I'm talking with Dr. Barbara Stanley about her intervention for suicidal veterans. What kind of resources are needed to implement this intervention in the emergency department?
Actually, it's a minimum level of resources that are needed, but it requires kind of refocusing the way that we run both the emergency room and then what we do with people once they leave the emergency room. So first of all, it means that for psychiatrists, they have to think about doing an intervention as opposed to just evaluating people and triaging them in the emergency room. They have to think about, okay, so we're going to do a brief intervention right then and there. And so it means that people need more time. And so that's primarily, in the emergency room, that's primarily what is needed, the opportunity to have the time to do a 30 or 45-minute intervention, which can be difficult given that many emergency rooms are very busy. The other thing that is needed is a re-shifting of the system that would say that follow-up phone calls after an ED visit are an important clinical intervention. And so in some way or another, the system would have to be modified to consider follow-up phone calls clinical contacts. The other thing that I would say is that what we did in our study is we had the person who gave the intervention in the emergency room, for the most part, be the person who did the follow-up phone calls. And so that may or may not be readily translated if somebody goes to try to implement this. And we think that even if it's not the same person doing the intervention in the emergency room as the person who is doing the follow-up phone calls, that we still think that we'll get a good result as long as that person who does the follow-up phone calls has access to the person's safety plan.
Do you think that this intervention is applicable to the civilian population?
Oh, it definitely is, and as a matter of fact, it started in civilian patients, and the VA adopted the intervention, and so now we've been working with several states across the country to train their staff statewide on aspects of this intervention. And so there are emergency rooms, inpatient units, outpatient departments that have adopted this safety planning intervention in particular, statewide.